So today we'll do the maternal complications of pregnancy from USMLE first aid step 2 textbook. I'm on page number 438. Let's read this topic. So maternal complication of pregnancy, the first one which comes is hyperemesis gravidarum. Now this is persistent vomiting not related to other causes, leading to starvation, ketosis, and weight loss. And usually at least a 5% decrease from the pre-pregnancy weight occurs in this. So this is important. Usually we are intending to add on weight during pregnancy, and here there's loss of weight of 4%, 5%. It's more common in first pregnancy, multiple gestations, and molar pregnancies. Increase in the beta HCG and increase in the estradiol have been implicated in pathophysiology. Distinguished from nausea and vomiting of pregnancy by severity, presence of weight loss and ketosis and timing. Acid reflux, gastroenteritis, hyperthyroidism, and neurological conditions can also cause nausea and vomiting and should be on the differential diagnosis. You always have to rule out trophoblastic disease with ultrasound sonography in a pregnant patient who presents with severe nausea and vomiting. Clinical diagnosis, best initial test, USG for trophoblastic disease or multiple gestation. Evaluation for electrolyte abnormalities such as hypokalemia, abnormal liver enzymes, amylase, and lipase. Wernicke encephalopathy from beta 1 deficiency, possibly in severe cases, the physicians can look for a gait ataxia and locomotor dysfunction. So, the best initial treatment for this will be dietary changes and doxylamine pyridoxine. This you need to remember. If no response, you discontinue doxylamine and use metoclopramide, promethazine, or prochlorperazine. Consider ondansetron if vomiting is not resolved with treatment mentioned earlier. And if dehydrated, we need to administer IV fluids, IV nutritional supplements, and ondansetron IV. Diabetes in pregnancy is divided into two categories, progestational and gestational. Progestational, somebody who's got diabetes before pregnancy, such as type 1 or type 2. Gestational onset is during pregnancy. Consider early screening, fasting glucose, first trimester HbA1c, or early glucose tolerance test for the following risk factors. Imperative to do this. Somebody who's overweight or obese or with BMI of 25. This we're talking about pre-pregnancy. Weight, physical inactivity, first degree relatives with diabetes have previously given birth to an infant weighing 4 kgs or more. And previously gestational diabetes, women with polycystic ovarian syndrome, HbA1c more than or equal to 5.7%, impaired glucose tolerance or impaired fasting glucose on previous testing, history of cardiovascular disease, other clinical conditions associated with insulin resistance, such as metabolic syndrome and acanthosis nigricans. Pre-gestational diabetes observed in 1% of all pregnancies. Insulin requirements may increase as much as threefold. Poorly controlled diabetes is associated with an increased risk for congenital malformation, fetal loss, and maternal or fetal morbidity during labor and delivery. Greater than 8, investigate if HbA1c is more than 8%, look for congenital abnormalities. Testing and treatment, mother, renal, ophthalmologic, and cardiac evaluation to assess some end organ damage. Best initial treatment, lifestyle modification with diet and exercise, addition of insulin therapy if poor response, strict glucose control if important to minimize fetal defect. So the fasting morning should be less than or equal to 95 milligram per DL, and 2 hour postprandial should be less than 120 milligram per DL. Delivery and postpartum. Maintain normoglycemia 80 to 100 milligram per DL during labor with an IV insulin drip and hourly glucose measurement. Delivery and postpartum, maintain normoglycemia 80 to 100 milligram per DL during labor with an IV insulin drip and hourly glucose measurement. Consider delivery in the setting of poor maternal glucose, pre-eclampsia, macrosomia, or evidence of fetal lung maturity, preferably after 32 weeks. Consider C-section in the setting of estimated fetal weight more than 4,500 grams. Fetus 16 to 24 weeks, ultrasonography to determine the fetal anatomy. 32 to 34 weeks, antepartum fetal surveillance such as NST, contraction test, stress test, biophysical profile, if poor glucose control or small vessel disease. Hospitalization of maternal DM has been poorly controlled or fetal parameters are concerned. Serial ultrasonogram for fetal growth, complication, pre-gestational diabetes is a risk factor for a variety of antepartum, intrapartum, and postpartum maternal and fetal complications. Tight glycemic control is the best way to prevent these complications. Gestational diabetes, carbohydrate intolerance of variable severity first diagnosed during pregnancy, occurrence in 3% to 5% of all pregnancy and is usually diagnosed in the second trimester. Maternal complications, pre-gestational diabetes, this is important. So the mother can occur, there can be diabetes ketoacidosis type 1 or hyperglycemia or HHS, that is hyperglycemic hyperosmolar non-ketotic coma, pre-eclampsia eclampsia, cephalopelvic disproportion and needed for C-section, preterm labor, infection, polyhydramnios, postpartum hemorrhage and maternal mortality. Fetal complications, there can be a small left colon syndrome, macrosomia or FGR, cardiac and renal defects, neural tube defects, hypocalcemia, polycythemia, hyperbilirubinemia, hyperglycemia from hyperinsulinemia, respiratory distress syndrome, birth injury, perinatal mortality. So all these are the complications that can occur in a patient with pre-gestational diabetes mellitus. Okay, right. So somebody with history in diabetes will be obviously mostly asymptomatic, may present with edema, okay, and polyhydramnios, large for gestational age in infants, and let's see, more than 90th percentile. Best initial test is to do a routine screen with a 1 hour 50-gram glucose challenge. Okay? And venous plasma glucose measured 1 hour later, performed at 24 to 28 weeks, values of more than or equal to 140 milligram per DL. This is considered abnormal. Confirmation with an oral 3 hour 100-gram glucose tolerance test. Next test of screening test showing any two of the following: fasting more than 95 1 hour more than 180, 2 hour more than 155, and 3 hour more than 140. So you want, you can. Depending on the exam, you need to remember, but I feel definitely for the MBBS level, this is required. So how will you remember? Fasting 95, then this is almost double, 180, then 155. This is reduced by around 25, and this is reduced by around 15 after 1 hour. Doubled, minus 25 and minus 50. I think this we can remember. So 95, 180, 155, 140. Remember this. Mother, how will you treat men? Best initial treatment according to the ADA diet, regular exercise, strict glucose monitoring 4 times per day. This is imperative for females. Insulin is the gold standard if dietary control is insufficient. Tight maternal glucose control, fasting less than 95. 1 hour postprandial should be less than 140, and 2 hour postprandial should be less than 120. So this is your target. Okay. Intrapartum insulin and dextrose to maintain tight control during delivery needs to be given. Fetus, you need to do a periodic USG and NST to assess fetal growth and well-being. Recommend induction of labor at 39 to 40 weeks in patients with um, gestational diabetes who are controlled on insulin. Okay, so this is imperative, again important. Complication, more than 50% of patients with gestational develop glucose intolerance and or type 2 diabetes later in life. So at 6 to 12 weeks postpartum, the physician should screen for diabetes, 75-gram 2-hour GTT, and repeat testing every 3 hours if normal results. Hypertensive disease in pregnancy, chronic and gestational hypertension, defined as follows. Chronic hypertension presents before conception or at less than 20 weeks. So this is important. Okay, not only before conception, but even in the first trimester, if the patient is having, then also they are considering it as chronic. Now, this can be diagnosed postpartum if increased blood pressure persists more than 12 weeks. So even after postpartum, even postpartum, more than 12 weeks, if the hypertension is there, then it will be gestational hypertension. Possibly for up to 1/3 of patients with chronic hypertension to develop superimposed preeclampsia. Gestational hypertension, idiopathic hypertension, systolic blood pressure more than or equal to 140 or diastolic blood pressure more than or equal to 90 measured twice, that is more than 4 hours apart, without significant proteinuria less than 300 milligrams per liter. Develops at more than or equal to 20 weeks, possibly for up to 25% of patients with gestational hypertension to develop preeclampsia, most normalized within 12 weeks after pregnancy. Treatment, close monitoring of BP, best initial treatment with appropriate antihypertensive, example methyl dopa, labetalol, and nifedipine. If there is a systolic BP of more than or equal to 160 millimeter mercury or diastolic BP of more than or equal to 110, this is hypertensive crisis that calls for labetalol, hydrolazine, or nifedipine because of the short onset of action. These are some things which are going to work immediately. The patient should not take ACE inhibitors or diuretics. ACE inhibitors are known to lead to uterine ischemia and fetal renal damage. Diuretics can aggravate low plasma volume to the point of uterine ischemia. So both of them can cause uterine ischemia. So this is important, you might ask. Similar to those of Preeclampsia, obviously, the complications will be preeclampsia. We'll see now, so we'll get to know the complications of hypertension as well. New onset hypertension, systolic BP more than 140 or diastolic more than 90, proteinuria of more than 300 milligram protein in 24-hour period, or elevated urine or creatinine ratio of 0.3 or more, occurring at more than 20 weeks gestation or up to 6 weeks post delivery. Okay, so this is important. 0.3 protein creatinine ratio occurring at more than 20 weeks gestation up to 6 weeks post delivery. Preeclampsia with severe features defined as new onset hypertension with new onset of so when you're talking about preeclampsia with severe features defined as new onset hypertension with new onset of any of the following features with or without proteinuria. So new onset hypertension with or without proteinuria. So this there can be preeclampsia without proteinuria. Suppose if the platelet count is less than 1 lakh per microliter, if the creatinine has shooted more than 1.1 or doubling of the creatinine concentration in the absence of other renal damage. Remember when we were doing the basics of physiology in pregnancy, the creatinine was supposed to be around half of what normally it does. Suppose if the pregnant woman had 0.8 creatinine, then it should go down to around 0.5 to zero point 0.4 during pregnancy. The GFR increases, creatinine drops down, cardiac output increases. So, if the patient is coming with a creatinine of 1 or 1.1, that means there's something really wrong in the kidneys. Liver transaminase at least twice the upper limit of normal. Pulmonary edema, neurological or visual symptoms, new onset headache, which is unresponsive to medication and not accounted for by alternative diagnosis. HELP syndrome, this is hemolysis, elevated liver function test, and low platelet syndrome, which is a variety of severe preeclampsia with severe features, consist of hemolytic anemia, elevated liver enzymes, and low platelet. The etiology is unknown, but it's a favorite in all the exams. Clinical manifestations are explained by vasospasms leading to distension of hepatic capsule, hemorrhage, and organ necrosis. Risk factors of HELP syndromes are nulliparity, extremes of ages less than 20 and more than 35, multiple gestation, molar pregnancy, renal disease caused by SLE or type 1 diabetes, a family history of preeclampsia and chronic hypertension, and indication for delivery. Now, treatment recommend low dose aspirin daily during the pregnancy if the patient has this. Delivery of the fetus is the only cure for preeclampsia. Close to term or worsening preeclampsia induce delivery with IV oxytocin, prostaglandin, or amiodarone. Delivery should occur no later than 37 weeks. Presentation of preeclampsia and eclampsia. Preeclampsia usually asymptomatic, blood pressures around more than or equal to 140/90 on 2 occasions, 4 hours apart, and proteinuria of more than 300 milligram, 24 hours, or 2 urine dipstick. Delivery at 37 weeks. What about preeclampsia with severe features? So this patient will have any of the following: blood pressure more than or equal to 160 by 110 on 2 occasions, more than 4 hours apart, cerebral changes such as severe headache, somnolence, visual changes, blurred vision, scotomata, progressive renal insufficiency, pulmonary edema, right upper quadrant pain, hemolysis, elevated liver enzymes, thrombocytopenia. This case, you need to admit the patient, so hospitalization is necessary. Blood pressure control. Delivery by 34 weeks must balance maternal risk with risk of prematurity in the infant. Eclampsia, most common signs present preceding an enclamping attack is headache, visual changes, and right or upper quadrant epigastric pain. Thing which I had for right upper quadrant epigastric pain is also there in eclampsia. There are severe seizures if not controlled with anticonvulsant therapy, immediate delivery, far from term, less than 34 weeks. Far from term, less than 34 weeks, provide expected management with close surveillance, hospital admission for uncontrolled severe range blood pressures is needed. Okay. Even if when the patient is far from term, of course, termination is not um, um, done. You do expected management with close surveillance. Prevent intrapartum seizure with a continuous magnesium sulfate drip. Continue seizure prophylaxis for 24 hours. Postpartum, treat magnesium toxicity with IV calcium gluconate. Pre-eclampsia with severe features, control the blood pressure with labetalol and or hydrolazine. Goal is less than 160 with a diastolic blood pressure of 90 millimeter mercury to maintain fetal blood flow. Provide a continuous magnesium sulfate drip. Deliver by induction or C-section once in term. Watch for signs of magnesium toxicity, loss of deep tendon reflexes, respiratory paralysis or coma. Complications, prematurity, fetal distress, stillbirth, placental abruption, seizures, DIC, cerebral hemorrhage, serious retinal detachment, and fetal or maternal death can occur. Eclampsia is the new onset grand mal seizures in a patient with preeclampsia. We've already seen the signs and symptoms. The treatment will be delivery of the fetus is the only cure. Management of the maternal hypertension with labetalol or hydrolazine is done. How will you watch for magnesium toxicity? Very important. Magnesium is notorious with a narrow therapeutic index. It causes loss of deep tendon reflexes, respiratory paralysis, and coma. Okay, so, and you need to check for the urine amount of urine which is there. 36-year-old GP1 G1P0 Gravida 1 para 0 woman with a history of SLE at 37, 36 presents with a headache and right upper quadrant pain. She is admitted and found to have very high BP. When tested twice, she has protein. What will be, she is BP controlled with labetalol. And what are the next step in management? So, what will you do in this case? You need to deliver this case. Okay. So, after controlling the blood pressure, you need to deliver this case. She is already 36 weeks. Is more than 34 and delivery will be her only cure in this case. Seizure control prophylaxis with magnesium. If the seizure recurs, what will you do now? First, you give magnesium. The next step will be to give diazepam. Monitor for clinical magnesium toxicity. There is no need to routinely monitor magnesium level and renal function is normal. Monitor the fetal status, control the blood pressure, limit few fluids, use urinary Foley's catheter for strict intake and output. Initiate emergent delivery once the patient is stable and convulsions are controlled. Postpartum management is the same as that for preeclampsia. Seizures may occur antepartum 25% or intrapartum or postpartum 25%. So intrapartum seizures are the maximum for in case of preeclampsia or eclampsia. Most seizure means eclampsia. Most occur within 48 hours after delivery. So you need to monitor this patient throughout the pregnancy, during the eclamptic period, intrapartum, postpartum, 48 hours. Complications are severe. There can be severe cerebral hemorrhage, aspirin pneumonia, hypoxic encephalopathy, thrombotic events, and fetal and maternal death. I'll stop with this and we'll continue with urinary tract infection and asymptomatic bacteria in our next class.